Well, we will go ahead and call the committee to order. And Madam Secretary, I welcome you to the Subcommittee on Labor, Health, and Human Services. And we'll just go ahead and I'll go ahead and have my opening statement, and I'm sure that Rosa, you'll have one as well. You are center of so many things that are going on right now in Washington that we're going to have a lot of questions for you. But I wanted to, first of all, remind everyone on the committee that we'll do the 5-minute rule as we always have, and we will go in order of appearance if somebody comes in after this. But Madam Secretary, we're pretty strict on the 5 minutes, so it applies to witnesses and members. I do have a lot of concerns in your budget. And last year, you had estimated in our questions that the cost of implementing the Affordable Care Act was between $5 and $10 billion. And that was, as I said, part of our congressional record. That's a big swing, but it's still an underestimation. If you look at this year's request, there's an assumption for a $430 million brand new mandatory program used for CMS program management, and then you assume $1.2 billion for next year for users fees, and then $639 million in annually appropriated discretionary dollars for the exchanges. That totals to $2.2 billion, which is a 41% increase over last year, our $643 million. So concerned about that, but then when we read further in your budget, if you add in approximately $21 billion other dollars that are out there for state exchange grants, consumer-operated oriented plan, pre-existing condition insurance plan, early retirement reinsurance, transitional reinsurance, risk adjustment program, and risk corridors. If you add those two together, it's $23 billion to run Obamacare. Right now, you have 4.2 million people who are in line to enroll. Some of them are enrolled, but not all of them are enrolled right now. Your estimation is that 8 million people will be enrolled next year. If you look at that 8 million people, compare it to the 23, that it comes out to nearly $3,000 per enrollee. Now, the President said repeatedly, that the average person would have a $2,500 premium decrease. But just for the government to get involved, it's $3,000 per enrollee. So not only does that decrease has not happened, but you have this huge government expansion and burden, because in addition to that $3,000, the insurance companies, of course, have an overhead charge of their own. So when we talk about this this new law and the cost of it, to me, that's the most disturbing of anything. I will say in my discussions with constituents, I have not found anybody who's had a premium decrease. I have not talked to many businesses who have created more jobs or found Obamacare compliance business friendly in terms of creating more jobs. So to me, it's a failure. It was supposed to decrease premiums and increase access, but when businesses are not creating jobs or putting people on a part-time basis in order to get around Obamacare or keeping the number of employees below 50, then it's been a failure on both sides of it, the premium side and the access side. So those are my concerns, and we will look forward to having good exchanges on it. And let me yield to my friend, the ranking member, Ms. Delora.
Thank you very much, Mr. Chairman, and welcome, Madam Secretary. Thank you very much for joining us. Thank you for all that you have done and are continuing to do to implement the Affordable Care Act, which in fact is a transformative law for American families. Before I begin, I want to make 3 important points to help guide our conversation this morning and to set the record straight. First, and despite what we're likely to hear, Congress has spent the last few years making deep and irresponsible cuts to non-defense discretionary spending. If history is any guide, the commentary will be to suggest that spending on these vital programs has grown or even exploded in the past decade. This is simply not true. Let us look at the evidence. A common means of comparing budget levels over time is to measure them relative to the size of the economy as a percentage of the gross domestic product. Using that measure, per capita inflation-adjusted spending on programs funded in the labor HHS bill over the past decade has been cut by nearly 15%, from 1.2% of GDP 10 years ago to just 0.95% in the 2014 budget we enacted 2 months ago. NIH has been cut by almost $1.1 billion, HRSA by $1.4 billion, CDC by $723 million. Job training programs of the Department of Labor have been cut by $696 million, Title I by $107 million, IDEA by $32 million. The list goes on and on. Some of my colleagues may applaud these deep cuts as a necessary austerity, but in real-life terms, what we're really talking about here is less money for education, less money for scientific research, less money for public health investments, among other critical priorities across the labor HHS bill. We are not doing more with less. We are doing less with less. We're still working to recover from the worst recession in generations, and yet we are shortchanging the critical investments in our future that actually grow the economy and save money in the long run. The recent budget agreement was a small step in the right direction in that it reversed some and some only of the deep and indiscriminate sequester cuts. But we still have a long way to go. For example, 2014 budget restored only 58% of the sequestration for NIH, a critical driver of jobs and health. CDC remains $100 million below its funding level prior to the onset of sequestration, despite the continued emergence of public health threats. Just 2 examples of where we fell short. There are many more. Second, I want to highlight the success of the Affordable Care Act. We all know there were serious problems with the initial rollout of healthcare.gov last fall, and I expect we will spend time this morning discussing what went wrong there. But I also want to make sure we acknowledge and that we applaud the many policy successes we have seen so far. Since the healthcare.gov website fixes went live, enrollment numbers have shot up nationally. Over 13 million Americans have signed up for affordable insurance coverage, many for the first time. In my state, Access Health Connecticut, the state-run exchange, had a goal of enrolling 100,000 people by March 1st. It has enrolled close to 160,000 Connecticut citizens. It is coming in on time and under budget. A new Gallup poll shows that since the Affordable Care Act went into effect, the uninsured rate in America is dropping among every single demographic group, especially low-income Americans. Healthcare spending growth is the lowest on record. In fact, healthcare spending growth rates over the past few years are less than 1/3 of the long-term historical average going back more than 50 years. Due to the slower growth in healthcare spending, CBO projects that the Affordable Care Act will reduce federal deficits by $100 billion in the next 10 years and by an average of $83 billion per year in the subsequent decade. I repeat, CBO, Affordable Care Act, will reduce the federal deficit by $100 billion in the next 10 years and an average of $83 billion per year in the subsequent decade. So notwithstanding the rhetoric, evidence so far suggests that the Affordable Care Act is working. It is providing more Americans access to affordable insurance, a higher quality of care, while working to slow the growth of health care spending and health care inflation. Let us not lose the forest for the trees. Americans do not want us to repeal the Affordable Care Act. They want us to fix what is not working as well as intended and to move forward. Third, I want to turn to the main question before us today, the Health and Human Services budget request for fiscal year 2015. I was pleased to see modest increases for critical programs and priorities like biomedical research and early childhood programs in the President's request. At the same time, other parts of this request give me serious pause. For example, the proposal would further reduce the Low-Income Home Energy Assistance Program, or LIHEAP, by another $625 million. Right now, LIHEAP's current funding is still below the pre-sequester level. I'm also troubled by the proposal to cut community services programs by nearly one-half, and I hope we can talk about these priorities. Finally, I have a question for my fellow members of the subcommittee, particularly those who are concerned about waste, fraud, and abuse in healthcare. Why did we choose not to fully fund the healthcare fraud and abuse control program in the 2014 budget? This program acts as a deterrent against fraud and overpayments in our Medicare system. It saves billions of dollars of taxpayer money. It ensures that our seniors receive the benefits that they have earned. And yet, the majority left an additional $329 million for this program on the table, even though it would not have cost this committee a penny from other programs due to the cap adjustment for program integrity initiatives. These additional funds would have saved taxpayers approximately $2.5 billion if we had included them in the recent budget. If we're concerned, and truly concerned, about stopping healthcare fraud, reducing the deficit, we need to fund the programs that work to do so. I hope my colleagues will commit to fully fund this program for 2015. So we have much to talk about, and with that in mind, Secretary Sebelius, I thank you for coming today, for your hard work on behalf of our families. It's a tough job. I look forward to hearing your testimony and for the discussion. Many thanks. Thank you, Mr. Chairman.
Thank you, Ms. Laura. Perhaps we could find some compromise. We could take the money out of Obamacare and put it into fraud. What do you think? I don't think you'll accept that.
Trying to repeal the bill 51 times now, I think. You know, they say insanity is repetition over and over and over again.
You mean like spending more money on big government for solutions? As you can tell, Ms. Secretary, my good friend and I may have a slightly different view of this, but we share a lot of views in common on other issues, and we're looking forward to your testimony. So with that, I'll yield the floor to you, and again, 5 minutes, so you may need to skip around, but we have your written testimony. Thank you.
Well, good morning, Chairman Kingston and Ranking Member DeLauro, members of the committee. I'm pleased to be here again. As President Obama has said, the budget you consider is about more than numbers. It's about our values and what sort of future we want to give to our children. Among these values are opportunity for all, economic growth, and the security of our families. HHS has a very important role to play in each of these areas. Opportunity for all begins at home. Every child deserves the opportunity of a healthy start. And as the President reminded us in his State of the Union, research shows that one of the best investments we can make in a child's life is high-quality early education. Now, studies show that the return on early education investments is at least 7 to 1, far exceeding any investment in the stock market. Our budget puts a special focus on a birth to kindergarten pathway. It expands early Head Start child care partnerships so we can give more children access to high-quality preschool and child care. And if you move forward with the President's Opportunity, Growth, and Security Initiative with an additional investment, which could be paid for by closing tax loopholes, we provide an additional 100,000 children with access to high-quality early education. The budget before you also invests to empower children's first and best teachers, their parents. It does so by expanding voluntary home visitation initiatives, which are fully paid for by a tobacco tax. Not only are we able to help more children and their parents without adding a dime to the deficit, but we'll be able to discourage more of our children from smoking. Now, we know that the tobacco tax deters would-be smoker, particularly young smokers. We also know that 3,000 young Americans a day try their first cigarette, and 1,000 of them become daily smokers. Therefore, we're also investing in more prevention, education, and media campaigns that have been shown to deliver results. We believe that we can make this generation a tobacco-free generation if we're willing to take action. Early childhood and tobacco prevention efforts are important strategies for expanding opportunity and providing families with security. Affordable health care is another. No one can start a new business or save for retirement when they're drowning in medical bills. This budget protects the progress we've made in the last 4 years to expand the opportunity of more affordable health coverage to more Americans. Through the end of February, 4.2 million Americans signed up for affordable health insurance plans through the marketplace. And as you know, these are private plans in a private market. We expect this number to rise by the March 31st deadline as more Americans learn just how affordable health coverage really is. Sorry. Having trouble here with my... This budget is a job creator. It bolsters some of our most important sectors of our nation's innovation economy by investing in the NIH-funded BRAIN initiative, vaccine development, and other cost-cutting projects. It also creates jobs by increasing our primary care workforce through investments we make in the Health Care Workforce Initiative and the National Health Service Corps. Ultimately, we all agree that there can be no opportunity without security. And the investments we're requesting in ASPR, CDC, and the NIH matter to the security of every family. This budget requests funds to advance the development of medical countermeasures against chemical, biological, and radiological threats. We also move influenza preparedness forward, as well as vaccine development and the search for antivirals that are effective against drug resistance and virus mutation. In addition, because no American should get sick as a result of a hospital stay, the budget invests in CDC and AHRQ's work to protect hospital patients from healthcare-associated infections. This budget also protects the security of some of our most vulnerable populations. We expand elder justice initiatives that protect our parents from abuse, neglect, and exploitation. We support the Ryan White HIV/AIDS program so we can expand access to care and condition management to 500,000 lower-income Americans living with HIV and AIDS. We make these investments while also making tough, fiscally responsible choices, and our budget contributes $369 billion to deficit reduction over the next 10 years. And we will, as Representative DeLauro has said, continue to fight waste, fraud, and abuse. Every dollar we have invested in the Healthcare Fraud and Abuse Control Initiative, we have recovered $8.10. Last year, that totaled a record-breaking $4.3 billion. In summary, this budget expands the opportunity to more Americans, including the opportunity of a healthy childhood, the opportunity of affordable health coverage, and the opportunity of a job. And with that, Mr. Chairman, I'd be pleased to answer the committee's questions.
Thank you, Madam Secretary. I was watching an interview with somebody who was knowledgeable of cybersecurity, and he said that the Obamacare webpage or the exchange sites, and I know there's different ones, but he said it was 4 minutes away from being able to be hacked by the average hacker to get income information, healthcare information, family information. Do you agree or disagree with that, and how secure are the web pages?
Well, I know that cybersecurity is certainly a huge issue and priority, and it's a huge issue for us. And Chairman Kingston, first of all, we collect no health information because it's currently not needed, because insurance companies can no longer lock anybody out with health information. So that is not collected. Secondly, the hub, which is the central focus of both the state-based marketplaces and the federal marketplace, doesn't store any information. It's a router to ping other secure government systems and deliver back information. But finally, the website, the federal marketplace, and the states have been built to the highest federal standards. We have ongoing and continuous penetration testing. As recently as mid-December, we conducted a full security control analysis and had a green light to no high findings were done in the end-to-end testing that was performed in the secure lockdown site. We have continuous testing not only from HHS outside entities, but on an ongoing basis, penetration testing, and there has been no successful malicious attempt to get personally identifiable information. But we are continuing to improve the site. I think the private sector site breaches that we heard about in late in the year with a number of top retailers have sent shockwaves through everyone, and I think it's incumbent on all of us, not just on the new marketplace, but we run the Medicare system. We have Medicaid information. We have a lot of personally identifiable information. It's always been a priority, but believe me, we are working on a continuous basis to increase our security efforts.
Okay. Question about the implementation. I know that there was part of the law when it was passed that said that the White House could waive certain provisions in order to implement it, but now that the bill or the law has been the law of the land for 3 years?
Four.
I don't understand the authority in which the administration uses to waive certain requirements on mandates, and how many mandates have been waived? I hear 20, I hear 27, I hear 28.
Well, Mr. Chairman, first of all, I think this has been a multi-year, as we just discussed, implementation effort, and what we are attempting to do is have a smooth transition into the new marketplace. Our agency, as well as other departments across the federal government, have fairly broad discretion authority in terms of implementation efforts, and at each point along the way, excuse me, we have gotten legal counsel approval for the steps we have taken. Nothing has been discarded in terms of the law. The law is still very much in place. What we are doing with some of the features of the law in terms of having a transition most focused on people who have insurance, coming into compliance with some of the new features of the plans, to gradually phase those in over a period of time. But they will all be in place, they will all be enforced, and they are all still very much a part of the law.
Could you provide us with that legal opinion?
I'd be happy to.
And could you do it today? I don't know. I just don't want it to disappear.
Sure, it won't disappear, but I'll do it as quickly as we can.
Okay, I'm going to yield to you, Rosa, because of time. Thanks.
Thank you, Mr. Chairman. Madam Secretary, I have spent my entire career fighting to ensure universal access to high-quality, affordable health care. And I want to again say thank you to you for your hard work to bring this nation closer to that reality. I have 3 or 4 questions, of which I just want you to, I would like to have you just confirm. There's, at this juncture, no need for lengthy answers here. Question, for instance, isn't it true that about 3 million young adults have coverage today because the ACA allows them to stay on their parents' plans?
There are about 7 million who are staying on their parents' plan. The insurers tell us at least 3 million of those folks had no insurance prior to being on their parents' plan.
Thank you. Isn't it true that the American consumers have saved $1.5 billion in premium costs due to the Affordable Care Act? Example, medical loss ratio requires insurance companies to spend at least 80% of their collections from premiums on providing actual health care services as opposed to administrative costs, marketing, or salaries for high-paid executives. Hasn't this resulted in significant rebates to American families?
Congresswoman, consumers have gotten rebates, small business owners have gotten rebates, as well as using the new authority that they have. A number of state insurance commissioners have turned down what were double-digit rate hikes and made it very clear that they're not allowing those. So both have happened.
That last piece was true of the state of Connecticut in a double-digit rate hike. Question, isn't it true that seniors are saving almost $1,000 per person on drug costs due to the Affordable Care Act, due to closing the donut hole in Medicare Part D?
Well, the seniors who qualify for the donut hole, because they purchased those prescriptions, have saved at least $1,000 apiece on average because of the ACA provisions. Yes, ma'am.
One of the most important pieces of the Affordable Care Act is its focus on increasing access to preventive services. Isn't it true that more than 25 million Medicare beneficiaries are receiving free preventive care as a result of the Affordable Care Act?
Well, as you know, Congresswoman, not only do seniors receive that, but now insurance policies offer preventive services with no copays and no co-insurance. So cancer screenings and flu shots and children's immunizations are all part of what are insurance benefits.
Thank you. Last 3 years, real per capita annual growth of national health expenditures is only 1.3%. Less than a third of the long-term historical average, lower than the previous 3-year period, which coincided with the recession. There are many moving parts and pieces in the U.S. economy, but I think we could say that the Affordable Care Act has been successful in constraining the growth of health care spending. Can you talk about the impact the ACA is having on health care costs and health care spending? If the ACA continues to constrain the growth of health care expenditures, won't that wipe out a portion of the projected future deficits?
Well, Congresswoman, we're seeing the lowest health care increases in, some people say, in recorded history. Medicare is growing at a slower rate. It was up over 6% year in and year out in the decade before the ACA was passed. In 2010 to 2012, it grew at a rate of 1.6% per capita. Last year, 0.7% per capita, never seen in the 50 years of the program. Medicaid costs across the country are rising at about half the rate that they did prior to the ACA. If you compare the decade before and the 4 years since, it's about half. Overall health expenditures for the United States are rising at half the rate they did in the decade before as compared to the 4 years since the ACA. And private insurance rates are rising at about half the rate.
Mm-hmm. So overall, we are seeing a bending of that healthcare cost curve.
Significant. And initially, people said this was related to the recession. Health economists now are saying there's some fundamental transformation going on in the overall healthcare expenditure, and that's very good news.
Okay, thank you. I don't know if, well, let me move to the healthcare fraud and abuse, which you addressed in your commentary. I mentioned this in my opening statement. The Budget Control Act of 2011 authorizes 2 cap adjustments and program integrity initiatives in the labor HHS bill. The cap adjustments are provided for programs that actually reduce the budget deficit by preventing fraudulent expenditures in federal programs. Healthcare fraud and abuse control program is one of these programs, estimated to save nearly the $8 in taxpayer money for every dollar spent. Can you tell us about the fraud prevention activities that HHS could be pursuing this year but can't because of the FY14 bill that didn't fully fund this program? Let me just leave it there because my time might be running.
Part of the lesser-known features of the Affordable Care Act is it's probably one of the toughest anti-fraud measures ever passed by the United States Congress. You gave us a lot of new tools. You increased criminal penalties for fraudulent activity, gave us new resources to set up predictive modeling so we can do what the private sector does, is look at expenditures, and additional resources were used to expand the very successful on-the-ground strike forces of the Justice Department working with our fraud investigators. That combined has increased the number of arrests and trials and recoveries. So last year we announced $4.3 billion was put back in both Medicare and Medicaid trust funds thanks to those efforts. So we would be able to expand strike forces, do more vigilant activity. Medicare is a huge program, as is Medicaid. Fraud activity occurs, and the further we can get out ahead of it and not pay and chase, the better off we're going to be.
Can you just deal with what kind of money we're talking about? What kind of savings? Is that
well, as we have now, over the last couple of years, returned 8 to 1 for the dollars spent, brought back $8 that are put back in the trust
Gentlewoman's
fund.
time has expired.
Thank you. 8 to 1.
Mr. Fleischman.
Thank you.
Mr. Chairman, I understand that you wanted me to yield about a minute of my time, sir?
Let me just say this for the record to my friend, Mr. Lawrence, for the Secretary. Your budget last year was $5.3 billion, and this year is 23. That's not a decrease. Going from 5.3 billion to 23 billion is not a decrease in healthcare costs. And we can quote all this stuff and have all these nice rhetorical exchanges, but the numbers don't show that at all. Mr. Fleischman, thank you.
Thank you, Mr. Chairman. Good morning, Madam Secretary. Your administration has repeatedly given reprieve to business by delaying the mandate that requires large employers to provide health care coverage or pay fines. Yet, you refuse to consider granting that same option to individuals who are struggling to meet the requirements of Obamacare. In fact, your agency stated on Tuesday that you do not have, and I repeat, you do not have the statutory authority to delay the enrollment deadline, and in your testimony before the House Committee on Ways and Means yesterday, you stated that the administration will not delay the individual mandate or extend the 6-month open enrollment period scheduled to end March the 31st. Madam Secretary, I would like you to clarify whether you can think of any reason, and I state any reason, HHS would delay the March 31st deadline for enrollment, shop exchanges, or any other Obamacare deadlines. Please provide this subcommittee and the American people with a straight answer, and I want a yes or no answer. Will you or will you not delay the individual enrollment deadline on any other aspect of Obamacare?
The enrollment deadline will not be delayed, as I said yesterday. The shop doesn't have a deadline. Small business owners can sign up at any point, so they don't operate in an open enrollment period. That's the way that insurance market works. They don't have to worry. Anybody eligible for Medicaid can sign up at any time, as can small business owners. But the enrollment deadline, which was set out to end March 31st, will end March 31st.
Okay, so then we agree that there's no statutory authority to extend these deadlines and that they will not be extended.
The enrollment deadline will be March 31st.
Thank you. Mr. Chairman, I yield back.
Ms. Robel Howard.
Welcome, Madam Secretary. As you know, minority health in our country suffers disproportionately from the rest of the population, so it's important that every effort is made to reduce the racial and ethnic health disparities that exist in our country. Yet in your proposed budget, CDC's Racial and Ethnic Approaches to Community Health, the REACH initiative, which funds community-based programs and culturally tailored interventions to address health disparities, is eliminated. Programs that focus on healthcare workforce diversity, such as the Health Careers Opportunity Program and area health education centers, are also eliminated. And on top of the elimination of these programs, the budget of the Office of Minority Health is scheduled to be cut by 37%. I understand that these cuts are to replace REACH grants with grants that focus on chronic disease. How will these new grants replace the work and accomplishments of the REACH program? And what is the rationale for eliminating proven workforce diversity programs like HOP and AHEC, and for cutting the Office of Minority Health budget by 37%, which is about $21 million?
Well, Congresswoman, we share your focus and attention on reducing health disparities and providing funding for programs and services to improve health in minority communities. And let's just start with the Affordable Care Act, which has a significant impact, and probably the most significant impact on reducing disparities, since African Americans and Hispanics are more uninsured by population than their white neighbors and friends. But the budget has $11.9 billion for programs and services to improve the health in minority communities. We've got an additional $960 million going out to community health centers with new access points, and can serve up to 31 million patients. 62% of the health center patients are racial and ethnic minorities. There is new money going into the Indian Health Service, one of the least served population, to continue projects and reduce health disparities. An additional amount of money into the Ryan White HIV/AIDS program. CDC does suggest that rather than funding an independent REACH program, the new partnerships in community health, the grant programs, as well as the chronic disease and prevention programs, funding announcements will more than cover not only that population, but they think it will do it more efficiently. And while there is a decrease in the Office of Minority Health, I would say that the grants are coming to a natural end in that office, and we're looking at broader service programs that can pick up that focus and effort. Finally, we do have increased funding, which I think is critically important in the workforce areas, to make sure that we further diversify our workforce. So in the HRSA, in our project to increase the size, more than double the size of the National Health Service Corps, over 30%, an overrepresented group, are minorities already. We think that that will continue. More than half of the 1,100 core members in the pipeline are minorities, and that will make sure that people are actually in a more diversified workforce setting than we've ever had before in the history of this country.
I think that the concern is that some of the programs that you're talking about deal more with current health providers and enhancing their work. And the concern that, at least that I have, is that the programs that you're cutting are mostly about recruiting minority health providers and building a pipeline for future healthcare workers. So I guess my question would be is then how do these programs that you've just mentioned specifically address recruitment and retention of minority health providers, and how do they build this pipeline that is going to be so critical in the future?
Well, again, I would say that one of the most successful programs that we have is the National Health Service Corps. Overrepresented, 30% of the National Health Service Corps who receive scholarship and loan repayments are minorities. We currently have about 8,900 National Health Service Corps members in the country. This budget would bring that number to 15,000 and keep it at 15,000. That's a whole lot of new pipeline, and we will very much double down on the effort to make sure that minorities are overrepresented in that population. That's a new group of healthcare providers.
Mr. Joyce?
Thank you. Madam Secretary, CMS rules require the Federal Exchange and all state exchanges to implement a Small Business Health Options Program, otherwise known as SHOP, that provides an employer the ability to make available to their employees all exchange health plans at a metal level, for example, bronze, silver, gold, or platinum. This employee choice model is administratively complex. In 2013 and 2014, several states attempted to implement the employee choice approach, but encountered technical issues that require them to either take down or delay launching their SHOP program. Yet CMS still requires all states to have this ready to go later this year. An employee choice shop is an enormous IT undertaking across multiple business partners and vendors to allow for online shopping, enrollment, automated employer billing, and payment of health plans. However, there's little transparency into CMS progress in implementing this new shop model for 2015. In particular, details on key milestones for development, testing, and availability have not been released outside the government. More transparency is critical since CMS will be implementing SHOP in 37 states. Based on media reports, enrollment in state SHOP exchanges is minuscule. However, CMS hasn't released any data on how successful it has been in enrolling employers to date. Madam Secretary, how many employers are covered under the federal SHOP today?
Sir, I don't have that number off the top of my head, but I can get it for you today.
Well, thank you. I appreciate that.
Our last
today.
enrollment report would have it, and I just don't have the enrollment report with me.
Well, I'd appreciate that today.
Sure.
Thank you. And in light of the recent consumer experience rolling out the individual exchanges and the late announcement last November delaying SHOP on online enrollment for the federal exchanges, what assurances can you provide small employers that the rollout of the FF SHOP will be different from the individual consumer experience last October?
Well, Congressman, I have repeatedly said, and I'll say it again, the launch in October was failed and flawed. The good news was that the consumer had a very different experience 8 weeks after October 1st, but that is no excuse for the 8 weeks of really failed technology. We announced prior to the launch of the ACA that in the federal marketplace, states have made different choices with the state-based market, that while we would offer shop plans, we would not offer the second feature, as you say, employee choice. So an employer can choose among plans in the market in 2014, and a number are, and they are dealing with agents and brokers the way they have always dealt with small business coverage this year. We are online to have an automated system which will allow us to go to step 2 in the federal marketplace, so employees can actually choose between plans, which is a feature that a lot of small employers have never been able to offer. That technology will start to be built after open enrollment finishes, and we can get you regular updates. But I just got a report from the technology team that they feel that is feasible to have online by the time open enrollment starts on November 15th of 2014.
Well, see, Madam Secretary, last year when you were here, I asked you if there was a place that consumers or Americans could go to follow somewhere within the government the rollout of the Affordable Care Act. And I got a letter
They followed it.
Yeah, well, I got a letter back from you in August saying that, you'd get back to me yes again, and we got to follow it and didn't follow out all that well in October. Last year, CMS determined that it wouldn't be able to allow employees to select from any health plan on SHOP, and would instead focus on allowing small employers to enroll in a single health plan. Then in November, CMS announced that it would not be capable of even processing enrollment for employers. This meant that small employers that applied for coverage through the federal SHOP had to start over and apply for coverage directly through participating health plans. That was very disruptive to small employers. Shouldn't CMS prove that it could implement what it had planned for 2014 before attempting to implement the more complicated systems that would allow employees to choose from among multiple health plans?
Well, that's exactly what we're doing. We're trying to, this year, we have a system in place. If a small employer wants to take advantage of the tax credit, which is available to some small employers with low-wage workers, then enrolling, we have an arrangement with the insurers that they can qualify for the tax credit and enroll with insurers. If a small employer wants to offer coverage the way they always have and has no interest in the tax credit or isn't eligible for the tax credit, they are enrolling as they choose this year. And as I say, the automated version, including the employee choice, will be up and running.
Well, are CMS, its vendors, and business partners working under a coordinated federal timeline? And if so, what are the deadlines and key milestones in that timeline?
For this plan, I again, don't know that off the top of my head, but I can get that for you.
You can supply us those timelines?
Yes.
Ms. Lee?
Thank you.
Thank you, Madam Chair, Mr. Chair. Let me first say welcome and good to see you, Madam
you.
Secretary. Following up with Congresswoman Roy Ballard's remarks, and I associate myself with all of her remarks with regard to the budget cuts as it relates to the cuts to the Office of Minority Health. One of the issues, Congresswoman Roy Ballard, myself, and Congressman Honda helped negotiate the health disparities provisions in the Affordable Care Act for the specific purpose to really prioritize, of course, in a country that's rapidly becoming more diverse, to prioritize closing these gaps in communities of color. And so I'm really worried about these budget cuts and the fact that it doesn't really now appear that that is a priority. And in fact, we're not going to make a lot of progress in this. So I hope that we go back to the drawing board and look at this very, very carefully.
Well, again, Congresswoman, I would suggest that the budget before you has an increase in about $775 million in funding specifically for minority health issues, and that does not include any of the direct efforts through the Affordable Care Act to qualify people for health insurance. So in addition to that effort, there is an additional, and the programs include programs in HRSA, in the Indian Health Service, in the Office of Research and Quality, but we'd be glad to enumerate those programs and
It
get
would be
that to you.
good to see
Yes.
because, for instance, eliminating the funding for the REACH program, eliminating funding for the Centers for Excellence Healthcare Opportunities program, area health education centers, all of those have been reduced or eliminated. So we need to see how you're going to.
Absolutely, and in
do
some of
this.
those cases, the leaders of those agencies have made a determination not to decrease their efforts in minority health, but actually to expand them into broader programs that they thought would reach more of the population of interest.
Okay, yeah, I hope we have a chance to
And I'd be
sit down
glad
and
to
walk
do
through
that.
this. Let me ask you about gun violence. You know, it's been more than a year now since the tragedy at Sandy Hook in Connecticut, and a month and a half removed from the deadly mall shooting in Maryland. Of course, Congress, for obvious reasons, has failed to take a single step to address gun violence in America, taking innocent lives every day. Despite overwhelming public support, we've really been unable to act on something as non-controversial as background checks. And so as we wait, according to the Children's Defense Fund, they estimate that more than 21,000 children and teens have been shot by guns since this Congress alone. So I wanted to ask you about this study, the Institute of Medicine report that proposes a research agenda on gun violence, including key topics such as risk and protective factors and the characteristics of gun violence. Are you doing any gun violence prevention research? How does this budget attempt to address this in your proposals? And how do you see this gun violence issue as a public health problem? Because many want to see CDC and others begin to define at least part of it as a public health issue.
Well, I don't think there's much debate or dispute in the healthcare community that gun violence is a major public health problem. And not only has a serious economic cost, but a serious personal cost in loss of lives. In the President's Now is the Time agenda, some of those suggestions were dependent on congressional activity. Some were executive orders that could be carried out by departments, and one of them for our department was to ask both the NIH and the CDC to refocus on in the CDC incident surveillance of gun violence and producing data and information, which they are doing and will continue to do, and in the NIH to look at various causes and effects. We also have efforts in our substance abuse and mental health services that focus on not only the trauma that is created by survivors of gun violence and efforts to help victims, but a fairly significant increase, which was in the 2014 budget, and also recommendations for 2015, that we increase the number of mental health professionals. I mean, a greatly underserved area is often early intervention in mental health issues that could identify problems at the front end.
Thank you very much. Let's turn our attention a little bit to the NIH budget, which I understand comes in at $30.4 billion, and your statement says it increases $211 million over fiscal year 2014, reflecting the administration's priority to invest in innovative biomedical and behavioral research. But in fact, in the same budget, you increase the TAP from 2.5% to 3%, taking back $152 million of that $211 million increase. Is that correct?
The TAP has always been a part of our budget, yes, sir.
You are increasing the
We are
TAP,
increasing it, but
taking
that has always
$150
been-
million more than you would under the old TAP. Is that correct?
That is correct.
Okay, so basically the increase really, because of an accounting gimmick, is really only $50 million. The TAP you take from NIH is valued at, you would propose a $900 million TAP? Is that 3% of $30 billion? I mean, that's a back of an envelope estimation.
I assume that's correct.
Well,
Yes,
I think
yes.
the math of 3% of $30 billion is $900 million.
I just wasn't clear
So
that
if
30
we-
billion
so if in
was correct,
fact
sir.
In fact, your office didn't take the TAP, you could triple Alzheimer research at the NIH. You could increase Parkinson's research eightfold by leaving that $900 million in the NIH. I mean, you could double or increase 2.5 times the breast cancer research, but instead you choose to take a 3% TAP from the NIH. And the interesting thing is you say your budget reflects the administration's priority to invest in innovative research, but in fact, the best measure of the administration's priorities is where does the TAP money go? Because that really is your ability to set priorities of the administration. Am I correct, in fiscal year 2013, the last number that I have available, 0 TAP dollars were sent back to NIH for medical research? 0.
I can't
Out of-
confirm,
out
I
of-
can tell you Congress appropriates virtually all of the TAP from the HHS budget, so I think there are about $40 million of discretionary funding, so if Congress did not direct us to send TAP money to NIH, it probably isn't there.
Okay, so you'd be okay if we directed TAP money to the NIH?
As I say, Congress
because of the
has for
priority.
years appropriated the money that
So
comes in
you're
through the
not answering my question.
HHS
So you'd
TAP.
be okay if we directed that additional $900 million that your budget takes out of the NIH budget, the TAP, back to the NIH to restore medical research?
We will certainly work with Congress on whatever the direction is, but it is a congressional appropriation that has come
Good.
year in and year out to spend
I
that money,
understand,
so
but-
it is
but
not our
It was
discretion.
not our decision to increase the TAP from 2.5% to 3%. That was an administration decision in
think
this
that's
budget.
correct, but
I
you do
know that's correct,
appropriate
Madam
the money,
Secretary.
sir.
Listen, let's move on, because I only have a couple more minutes. The Maryland exchange is a disaster. Your Inspector General correctly agreed last week to inspect and to audit the Maryland exchange, but my understanding is they're coming back to the department for $38 million additional dollars to bail out an obviously failed exchange. Is it the intention of the department to provide that additional emergency funding?
So we have we do regular financial audits on all of the state-based markets. I'm not aware of this request. We have all of the IT funding for IT that isn't working under specific restrictions, and we will look at their proposal and see where
When did
they are
the
going
department
forward.
know that there are the tremendous problems in the Maryland exchange? The department is about to invest a total of $200 million, which, by the way, could double the Parkinson's research in the country if instead of wasting in the Maryland exchange, you had funded Parkinson's research. When did the department know about the failures in the Maryland exchange?
Sir, we got regular updates on
So the
when they
department
launched.
knew, so the department knew that this is a failure?
We did not know, we knew it was not working properly, starting.
Well, then, Madam
in
Secretary, I hope you
the
don't
fall.
send another $30 million there. Finally, the last thing is, earlier this year, CMS implemented extremely steep cuts to payments for certain epidural pain procedures I'm familiar with. I've never done them, but I'm familiar with them, to treat low back pain and other. They decreased by 56% the payment for these. I will tell you, Madam Secretary, that the effect of decreasing that is to ration this procedure to seniors with back pain. That's the effect of cutting 56% the payments. Due to the magnitude of the cuts, does CMS intend to revisit the decision through the agency's refinement process? You don't have to tell me now. If you can get back to staff within a couple of weeks, I'd appreciate whether that's going to be revisited through the refinement process.
I could certainly ask that question.
Thank you very much, Madam Secretary. I yield back.
Sorry, I wasn't sure I heard that correctly. Thank you for being here. Over the last few months, thousands of health insurance policyholders in my home state of Alabama have received notice that their plans have been canceled or altered. The costs have risen, some quite dramatically. A family with one's income premiums doubled from $420 to $940 a month. That being said, there's already a 3.5 administrative fee imposed on residents of states where the exchange is run by the federal government, like Alabama. Mr. Cohen told Congress in previous testimony that the percentage might have to be increased next year. Could you tell this committee when you expect to finalize the payment parameters rule for 2015?
Well, first of all, Congresswoman, there is no payment imposed on residents of your state. There is a fee on insurance companies.
That's passed on to the individuals.
If an insurance company chooses to do that, they can. If they choose to take it out of their profit margin, they can do that. They have rates already filed, so they can't pass it on. The rates are in the market
But
and
we're
they're locked
seeing,
in.
as a result of this administrative fee, we are getting direct stories from these individuals of a dramatic increase. So clearly, the fee plays a part of that.
And the rule has been finalized, so that is the fee that insurance companies will pay.
Do you believe it's reasonable to penalize these individuals with this administrative fee if their state was unable to operate, particularly because of insolvency, fiscal insolvency, especially these individuals that have already seen such a dramatic increase in their premiums?
Again, I'm not sure who's got fiscal insolvency. This is a fee on insurance companies who are seeing millions of new customers come into their businesses because of the Affordable Care Act, and the fee is to get us to the point where the marketplace will be self-sustaining. So the users and the companies who will make profit based on their new customers will actually be paying for the infrastructure to sell insurance products.
Right, and the reality, though, is that these dramatic increases are having an unbelievable effect on individuals that are having to make choices, quite frankly, between paying their mortgage or being able to pay for their health care. And I'm not making this up. They're calling my office. They're sending their premium statements showing us these are real lives that are being affected by these dramatic increases. I want to ask you just a series of questions based on your testimony about the 4.2 million individuals that are enrolled already, below the 7 million individual goal. And I heard you say, I believe, correct me if I'm wrong, you said as far as enrollees on the exchange that were previously insured. Did you state that number already?
I did not.
Okay, do you know that number?
I do not.
Can you get that to us today, please?
Insurance companies have that number. I do not have that number.
Okay, how many enrollees have currently paid premiums?
I do not have that number. As I told the committee members yesterday, we have aggregate numbers that are a month old from insurers. We do not have individual data from insurers. We will give you that as soon as we have it. I do not have accurate, timely information, and I can't give you that information. And we will never have until the fully automated system for the financial payment is in place, numbers on the individuals who are customers, who are paying their premiums, who are not eligible for the APTC. Customers pay the insurance companies. They do not pay the federal government. These are contracts between Blue Cross Blue Shield or Humana or Kaiser. And
so you don't know the cost per member or cost per month of the individual?
I can look on the website and tell you the cost per member and the cost per month. It varies by the tax credit they're liable for, but they are paying their insurance company. This is a private insurance company.
Why is HHS not tracking this information? I mean, Congress and this committee has appropriated billions of dollars to adequately implement this law, and you know, it's a wonder how where the justification is for not having these numbers.
We will have the numbers, but again, we do not have accurate information now because these are just being gathered. Insurers have more accurate information. The last number I heard was a comment by a couple of insurance leaders saying 80 to 85% of their newest customers have paid premiums in the month of January. Whether that's accurate or not, I cannot tell you, but we will get you timely information, accurate information as soon as we have it. But customers don't pay us. They are customers of insurance companies, not of the federal government.
Yield back.
Mr. Chairman, I'm sure you've heard the phrase that Congress is kind of like Hollywood for ugly people. You can see why I'm nervous with the proximity of the camera in that case.
I thought they were doing a dental exam or something. That's awfully close.
I feel like that as well.
You know, I'd have them back up a little, you know.
Madam Secretary, thanks for being here this morning. I have some questions. I'd like to go quickly if I could. In Ms. Roby's questions and your response to her, you indicated that you don't have information on some things. And one thing that we do know from the industry, not from the administration, is that something like 25 to 27% of the new enrollees through the exchanges previously did not have insurance. 3/4 of them were insured before. Do you find that an acceptable figure?
I'm thrilled that people are continuing to have coverage and that new folks are coming in. My understanding is that those numbers are changing over time, but again, the insurance companies are the best validator. I think what you're quoting may be a month or so old, so that newer numbers may look different, but again, the industry has those numbers.
We have no reason to believe, though, that information, though being a few weeks old, is less accurate. I mean, there's no...
I'm not talking about accuracy, I'm just saying it's changing over time, that some of the new uninsured individuals are coming in larger numbers.
Do you think it's going to be higher than 27%?
I think that's very likely.
Okay. Do you have a figure how much higher?
I really don't, sir. What we know is that a lot of people who have never had coverage before
Right.
are taking a lot longer to find out about the plan, to learn about insurance, to learn about their options.
We don't know, though. It may be less than that figure, right? It may be that we end up with less than...
I just said I don't know.
It seems to me this has been a terribly disruptive and a very infringing program to relieve what we know is going to be 30 million Americans without health insurance 10 years from now. It seems to me it's kind of like having a sliver under your nail and you cut off your finger to alleviate that. This has been such a disruptive and such a painful process, which will still leave tens of millions of Americans uninsured.
Well,
And that the
Congressman-
majority of them who had insurance, who are enrolling, had insurance previously.
Congressman, the individual market, which is what the new marketplace is looking at, as well as people who didn't have insurance coverage, was about 5% of insured Americans, 5%. And there definitely are people in that individual market who now have new plans and new policies, many at far lower rates
Right.
than they had before because they were locked into an old plan. There also are uninsured individuals coming into that marketplace. But we're talking about the vast majority of insured Americans whose plans were not impacted or affected except for more consumer protections than they've had before.
But once again, Madam Secretary, you make my point. 5% of these people, and yet this has been a terribly disruptive program for many, many Americans.
I'm saying those are the 5%. The formerly insured individuals who were in this marketplace are 5% of the insured number in America. The rest of the people who had insurance coverage were in employer-based coverage, in Medicare and Medicaid, and large
I
group
understand.
plans, and those have not been impacted.
But the point still being, only a small percentage of these who are joining the exchanges were uninsured before, and we will leave 30 million Americans without insurance at the end of 10 years. If I could move on now, would you agree, and it seems like it's not just the foundation, it is the very foundation of this law is the individual mandate, and that without that mandate, the entire bill will fail. And yet, well, and let me elaborate on that a little bit. That helps explain why the President has consistently said that he would veto even a bipartisan bill that delayed the mandate for any reason or in any way. And yet, in the last few weeks, the administration has essentially done that. They've delayed requirements that millions of Americans purchase health insurance or pay a penalty. They've essentially waived the individual mandate for the last few years. And it seems to me this would be something that the American people would need to know. And I would ask you, when you made that decision, did you hold any press conferences to announce those new that delay?
Sir, I assume you're talking about the issue where people who have coverage currently, who find their coverage changes to be unaffordable, could qualify for a hardship exemption and then be able to purchase catastrophic coverage.
Exactly.
What we're trying to do is keep people in the market, not have them leave the market, and that seemed like a logical step for people who already had coverage to keep that coverage. The hardship exemption has always been part of the law. The change was to say that if you had a hardship exemption because your new coverage was simply unaffordable, you also would
The
qualify
gentleman's
for
time has
catastrophic.
expired, but let me yield time to you to answer the question on my time. Excuse me?
That was my answer, sir.
Okay, let me make sure I understand that, though, because there was this news coverage that you could actually apply for a hardship if you lost your current policy and were unable to enroll, or it was too complicated to enroll. Is that a myth?
No. There are 9 categories that were spelled out, 8 or 9, in the law itself. The hardship exemption has always been there, and it's been really aimed at people who could not afford coverage, one way or the other, that they would be exempted from the mandate. There are a series of situations spelled out, and then a category that basically gave some broad discretion. As part of the transition into the new marketplace, we said that if you are in the individual market right now and cannot afford the new coverage, not only can you apply for the hardship exemption, which was always the case, but you could qualify to purchase, because you clearly want insurance, you've been insuring yourself, you've been in the market, you could qualify to purchase a catastrophic policy, which had a fairly narrow group of people. You had to be under 30, basically. So that was the change in the policy, not the hardship exemption, but the fact that they could qualify to buy catastrophic coverage to keep them in the market.
Okay. So it is still financially driven, not convenience driven, as the reports are.
Yes, sir. That's for the vast majority of cases. There were situations where, because of the technical issues in a state or two, and people were documented as attempting to purchase coverage and couldn't get into the site, they will be eligible for retroactive coverage based on their attempt to buy coverage. But it is really the case where it's a financial issue. The hardship exemption has always been there. We've said that, for instance, if you live in a state that has chosen not to expand Medicaid, and you would be Medicaid eligible, you are not liable for the individual penalty, because you're kind of out of luck if the state doesn't move forward on Medicaid expansion. So we have those categories, but they've always been part of the law.
Okay, let me ask you this, and maybe it would be useful for us to understand which states would fall in that category, but kind of moving on in a little slightly different direction, getting back to Dr. Harris's question about Maryland. And Maryland had such a disastrous rollout, but I understand that Oregon, Hawaii, and Minnesota, there's also been some enrollment problems. What kind of rehab do you have for those states? What kind of penalties? Do you just take over it? Because those Maryland numbers are unbelievable. I don't know how you could mess something up more than Maryland did. But I'd certainly like to know that a state there's some sort of penalty or rehab that would apply.
Well, as I indicated, Chairman, we have a regular financial audit that takes place. The portion of the Affordable Care Act that allows the state-based marketplaces has a funding stream, but we set up at the point that they put together plans. There's no question that some of these websites have been flawed and had more severe problems than the federal website had. We will look very carefully at any IT money going out. It is screened and qualified. We want these sites to work. We want the federal site to work. It took us 8 weeks of additional work to get it fixed. It was not ready as promised on October 1st. It was very functional by December 1st, but that work is underway in the states across the country. But we are restricting the IT funding. It goes out under audit. Whether or not the state then recovers funding from their contractors, repays the money, that's still an ongoing discussion.
Did anybody get fired over the rollout, or were there vendors who were totally eliminated from future bidding processes?
I can't tell you what has happened at the state level. That's a state-by-state choice. I know some of them have changed their vendors. I think a couple are suing their vendors. At the federal level, we made a series of decisions. We changed overall day-to-day management immediately at CMS. We have changed contractors at CMS. We have, we're in the process of hiring a full-time risk officer. We've asked the IG to become engaged and involved, which he has agreed to do with his team, and looking at all of the contractor issues. So we've taken a variety of steps.
Thank you. My time has expired. Ms. Lowy, we're very happy to have you with us.
Well, thank you so much, Chairman Kingston, Ranking Member DeLauro, and welcome Secretary Sebelius. I do apologize for arriving late. I was in a meeting with the Ukrainian Prime Minister, and then there's another hearing across the hall with Secretary Hagel and General Dempsey. So we are very busy today, but I was looking forward to seeing you. As so many of us would agree, the Department of Health and Human Services is so very important, and the responsibility for administering some of the key services and initiatives from early childhood education to seniors nutrition, I strongly believe that this committee must increase investments in those areas to grow our economy and improve the quality of life of all Americans. One of my top priorities is to increase investments in the National Institutes of Health. Not only does NIH's work lead to future improvements in quality of life and other benefits stemming from basic research when it comes to diseases and disorders such as autism, Alzheimer's, cancer, diabetes, food allergies, as well as the brain and big data initiatives. It is also an economic engine, and we have to remember that. Scientists in New York, for example, receive roughly $2 billion annually in the NIH grants, and every dollar of which generates $2.21 in economic activity. This is particularly important as there is a government-wide innovation deficit due to our inability to maintain adequate investments in research and development. And in the last 10 years, U.S. expenditures as a share of economic output have remained nearly constant, while China's has increased by nearly 90%, South Korea nearly 50%. We cannot afford flat budgets that hamper innovation. It is imperative we increase investments at the NIH. I also strongly support proposed increases to help and protect the most vulnerable, including Head Start, the Child Care Development Block Grant, healthcare fraud and abuse control, and to bolster safety and preparedness. I also believe it's important we adequately invest in pandemic influenza, BioShield, BARDA, hospital preparedness, and injury and violence prevention, including gun violence. That said, I have significant concerns with a number of proposed reductions, including CDC, LIHEAP, Children's Hospital, GME, Community Development Block Grant, and the Office on Women's Health, and too many other vital initiatives would receive stagnant funding, in some cases below the levels where they were just 2 years ago, including family planning. Madam Secretary, your department has wide-ranging responsibilities. I will do everything I can to ensure you have adequate resources when the committee writes its FY 2015 bill. And I'd like to ask one question. The 2014 bill restored some of the damage done to NIH by sequestration. But as you know, we were not able to fully replace those cuts, and instead fell short by a little more than $700 million. Meanwhile, your budget for FY 2014 includes a small increase of $200 million, but in my mind, this is far below the level that we need for biomedical research. And I just want to add, Mr. Chairman, I was privileged to attend a dinner for Research America last night. John Porter spoke. I was on this committee, as was my colleague, when he doubled the investment in the NIH. His leadership, a member of the Republican Party, the chair of this committee, made an extraordinary change. And when you heard these people with a whole range of illnesses speak and talk about what investments in the NIH have done for their families and other families, makes me proud to sit on this committee, to be part of the NIH advocacy group. So maybe you can share with us, for some who may not be as involved in the NIH, and don't interact with some of the people whose lives have been saved. What research activities could NIH pursue if additional resources were available?
Well, Congresswoman, I think that this administration certainly shares your view that now is the absolute worst time to back away from investments in research, and that NIH, which is the gold standard of the world in research, needs to be more adequately funded. One of the reasons that the President, I think, put forward the Opportunity, Growth, and Security Initiative, and with a series of pay-fors, saying this is where we should be. NIH has a huge portion of that investment. But the kinds of things that are going on the Brain Research Project with the DREAM Team and the research, the kind of new accelerations for cure that is underway, the pharmaceutical collaboration with the scientists is all breathtaking.
Thank you very much, Madam Secretary, and
Thank you very much.
Ranking Member. I would hope you'd join me with maybe saying that some of that increased TAP money should just be turned back over to the NIH. Maybe return that $150 million over there and increase that 211 to 350. Anyway, Ms. DeLauro is recognized for 5 minutes for a second round.
I thank you very much, Mr. Chairman. Just to tell you that the TAP effort is directed by the Congress, and particularly the TAP. It was the Bush administration that wanted to bring the TAP number to 2%. 2006, it went to 2.4%. We're 2.5%, and that is all directed through the Appropriations Committee. I would concur that the difference between 2.5 and 3, and that is what's being proposed. But please, people should understand where that evaluation TAP restriction comes from and where the responsibility lies. This Appropriations Committee needs to deal with that. Madam Secretary, let me ask you this question. How many people will be insured by the end of the decade? What is the anticipation that you think you'd be able to insure?
By the end of the decade?
Yeah.
Congresswoman, I don't know. I can give you that number. What I'm hoping is that many more states will join the 32 governors who are in the process of expanding Medicaid, which is a huge opportunity for lower-income working adults.
Which, quite frankly, they decided that they didn't want to do for whatever reasons they didn't want to do that, to expand coverage for people.
That's correct. But we do have 32 governors, Republicans and Democrats moving ahead. We know that the recent Gallup survey indicates that the rate of uninsurance in this country as of last month is already going down, and it has gone down to the tune of, they think, 3 to 4 million people. That's very good news. And I think that will continue. I think we will make a very serious dent in the so-called the uninsured gap that currently is there, because most people wanted insurance, they just couldn't afford the coverage.
Right. Which leads me to this comment that I want to make, given the conversation that we've listened to today. I think people sit here and believe that it was the halcyon days of health care that we had experienced before the Affordable Care Act. Let's just revisit. The healthcare system was failing people every year. Healthcare costs skyrocketed. Small businesses priced out of the market. Employers asking for higher contributions and co-pays and then dropping coverage. People with pre-existing conditions who were being socked or left on their own. Every single year, more people had no insurance whatsoever. Annual and lifetime limits on coverage that could lead to catastrophic expenses in the case of serious illnesses. Premiums that varied widely based on factors of age, gender, location, and health status. You could be canceled in a nanosecond for treatment that you were undergoing at that particular time. It sounds to me like some of the commentary here this morning is about taking us back to what was regarded as a failing healthcare system, when people were not guaranteed coverage for maternity, pediatric care, hospitalizations, families who, as I said, faced annual caps. It takes us back to a health insurance market that rejects people with a pre-existing condition, and they could be denied preventive services because they couldn't pay for it. What are we talking about here?
The American people do not want to see the Affordable Care Act repealed. They want fixes to be made. But let us look at together, in the bipartisan way that this committee came together around research under a John Porter or a Ralph Regula, that come together to say, how do we fix the problem so that in fact we can ensure people the opportunity, for some for the very first time in their lives, to have insurance coverage, or being told that their kid couldn't get insurance because they had asthma or were autistic. Let's focus on what the direction of this country ought to be in providing affordable health care coverage for this nation. That's what our moral responsibility and our obligation is to do, instead of carping. Let's not carp, but fix together what we can do for the benefit of the people that we represent. It's not about you and me, and I say that to my colleagues on both sides of the aisle. It's about the people who are not in the chamber. These are the people we came to represent. That's what the Affordable Care Act is doing, is to represent the people of this country. I yield back.
Mr. Fleischman.
Madam Secretary, thank you for confirming that you will not extend the open enrollment period for individuals the way that you all delayed Obamacare requirements for businesses. Will you delay the penalties under the individual mandate to give the people of the 3rd District of Tennessee and across this great nation the same reprieve that you've given businesses? If you're considering delaying the penalties, what is your legal authority to do so?
The penalty will be applied for people who can afford insurance coverage, who choose not to sign up during open enrollment. They will be liable for a penalty when their taxes are due in 2015, as is stated in the law.
Okay. Let me say this then. I want a clarification. If an individual does not select and pay for a plan by March 31st, will they or will they not be assessed a penalty?
Sir, as it states in the law, they will be assessed a penalty when their taxes are due in 2015. That's what the law says, and that is what will happen.
Thank you. In my remaining time, I'd like to respectfully respond to my colleague's last response and remarks, and I appreciate my distinguished colleague's passion about this issue. I also have passion about this issue. I was not in this great austere body when Obamacare was passed. I was elected in 2010. But I will say this. We did need health care reform in this country. There's no question about that. But we did not need Obamacare. 1/6 of our economy taken over by big government. In all due respect, I run into people all the time that say, no, I will not yield at this time. People come up to me all the time. Higher deductibles, higher premiums, more federal control. This is not good health care reform. Yes, we could have dealt with the issue of pre-existing conditions. We could have dealt with some of the provisions that most people approve, keeping children on your insurance to age 26. But we did not need, Ms. DeLauro. We did not need.
Will the gentleman yield?
I will not yield.
You're calling into question.
I did not.
And I'm listening to your rhetoric. And I'm listening to your rhetoric.
I call Obamacare into question. I call this administration into question.
You were not here when it passed.
The disaster that this has caused in terms of job creation, in terms of an overreach of government authority, in terms of an administration that appears to just basically piecemeal choose what they want to delay and not delay. So, Mr. Lauro, I will stand with the people of the great 3rd District of Tennessee and this nation to look for other alternatives other than Obamacare to solve this nightmare.
It's unfortunate that during the debate on affordable health care that the other side did not come forward with any
I yield to the chairman.
Thank you very much. No, actually, I guess of the members on this side of the aisle, none of us were here. But our understanding was, and I applaud you to on this side of the aisle, none of us were here when this bill was passed. And I applaud you for calling for bipartisanship. But I also urge you to remember, one of the reasons why this bill is failing is because it was not passed with bipartisan efforts. Madam Secretary, I'm going to follow up in the balance of Mr. Fleischman's time on that question of the hardship exceptions. Is the Wall Street Journal report from Monday morning incorrect? In fact, that all an individual needs to do is just to claim that they feel that the insurance policy is unaffordable and they will get a hardship exemption? Was it incorrect, their research? I'm sure you've seen it.
So what was said is that if you
Madam
had
Secretary,
a
are they
policy,
correct or not?
if you had a policy in
No, I'm not talking about someone who didn't have a policy. That's not what the editorial said. The editorial said someone who didn't have a policy.
The editorial was incorrect.
So
It's applied specifically to people who were in the market, who found their new policy unaffordable so that they could qualify. These are people who were insured, who wanted to keep
So the
insurance so
editorial
they
was
could
wrong.
qualify
Is that correct?
for.
In that rule, someone will not get a hardship. But you said that if you don't have a policy, in response to Mr. Fleischman, that if they can afford it, they will get a penalty. Madam Secretary, where's the definition of who can afford a policy? I never met someone who said they thought their policy was affordable. Where's the definition of, you said, and I quote you, if they can afford it? What's the definition of affording? And you can, I'm not going to tell you, my time is up, so you're going to have to answer me on my
I'd be
time.
happy to send you the rule as it stands
you're gonna have-
and
you're gonna have
outline
to
it. But
answer that for me.
This was specifically dealing with people who were
Ms.
in.
Rogal-Allard,
Dr. Harris, could I answer your question?
no,
Okay.
you will have it,
Thank
your
you.
chance,
Thank
my round. When it comes up, you can finish answering. Thank you, Madam Secretary.
Secretary Sebelius, each year your department's annual budget request for CDC is smaller than the year before. For example, the President's budget request to Congress for FY11 proposed a core budget for the CDC of $7.6 billion. That was $1 billion more than the $6.6 billion that you request today, even before adding losses for inflation. This 14% drop in the CDC's request over the last 4 years is actually stunning. And it seems to me that the CDC continues to disproportionately suffer from cuts compared to other HHS agencies. In fact, this year's budget request puts CDC's budget authority at levels lower than 2003 and includes mandatory prevention money allocated to the CDC from the Affordable Care Act that was intended to do more for the prevention than the core CDC activities. Given the state and local health departments rely on CDC funding to ensure adequate childhood immunization rates, develop capacity to respond effectively to public health emergencies, and to build capabilities to track environmental hazards, and given the fact that we're seeing old and new and sometimes mysterious diseases starting to pop up throughout the country, how will CDC continue to support these critical core public health functions with the cuts proposed in your budget? And what has been the impact of these cuts on CDC's prevention investments over the past 4 years, especially when you consider that the Public Health Fund mandatory spending was intended to supplement prevention efforts, not to supplant the CDC core budget?
Well, Congresswoman, I would say that a couple of things. Our discretionary budget for 2015 is over $1 billion smaller than the discretionary budget target for 2014. So we start with the fact that we have to allocate funds in a reduced budget environment. And we certainly share the concern, as I can assure you does Dr. Frieden, that the efforts of the Centers for Disease Control and Prevention is not only critically important as the backbone of public health, but is increasingly important in our global health initiative. So we've tried to focus the budget on the areas that he feels are top priorities. Some of the program eliminations were due to duplication of programs in other areas. Some are able to be reduced because we anticipate that more people will have health coverage to pay for services that an independent program would have paid for in the past, and the services will go on, we just don't need the money through CDC. But I am pleased that this budget does focus on things like increasing efforts in antimicrobial resistance, which is a huge health fear throughout the health system in the United States and throughout the world, and the CDC has incredible expertise. We are launching a new global health security initiative, which actually keeps the United States citizens safer and more secure to build capacity for surveillance and detection. Again, those are areas that Dr. Frieden wants to focus new funding, and so he has chosen to reduce some of the funding allocations. I would finally say that you're absolutely right that the prevention fund was to not supplant old efforts, but to enhance prevention efforts. I'm pleased to tell you that given the Congress activity in 2014, those efforts will be dedicated to prevention efforts, not used to backfill programs, and I think that we would see that going forward in 2015. We have, again, not suggested that the prevention fund be used to supplant CDC funding.
So are you saying that these cuts have had no negative impact then on
I would say
public
that
health efforts?
all cuts have negative impact, and certainly we saw during sequestration the very difficult time that a lot of public health, you saw the real impact that CDC had when they had to ask employees to stand down, and that sent shockwaves through states throughout the country. So every cut has an impact, but we, as I say, have $1 billion+ less to work with in 2015, and we are trying to be very strategic about how those funds are moving forward.
Okay, thank you.
Thank you very much. And before I start my question, I'm just going to comment. You know, we have still, I think, 5 members remaining in second round, so I know your time is valuable, so we've got to keep it to exactly 5 minutes so that we respect your time and your limitation here. So let me go ahead and let you answer the question that I interrupted your answer before for time purposes, but it has to be very specific. When you said that if they can afford it, someone who has never been insured before will get the penalty on this year's taxes. And that's what you said, if they can afford it.
In 2015.
Correct.
The fee will apply.
And who decides if they can afford it?
There is a hardship
So a
exemption.
person can apply for it.
If you self-attest, yes.
So self-attest, so the
There
Wall
are
Street
some-
Journal was right on track then.
Sir, there
Okay.
are criteria in the bill, there are 9 categories that were spelled
I
out in the law.
understand it. That's exactly what the Wall Street Journal said, self-attestation is
There are
on.
9 categories.
Madam Secretary, let's talk a little bit about some transparency. First, by the way, I just want to make a comment. I hope that you have the same enthusiasm for a non-medical marijuana-free generation that you have for a tobacco-free generation. Because, as you know, the Attorney General has decided not to pursue, not to enforce the Controlled Substance Act in 2 states. And I hope you agree with me that marijuana is at least as dangerous as tobacco. But let me go ahead and talk a little bit about some transparency, because I think Mr. Shimkus asked you back in December about the transparency of whether or not you can determine whether a plan on the exchange covers abortion. You said all you have to go is to the summary of benefits to see that. These are the summary of benefits of every exchange plan in Maryland. None of them have an indication whether they cover abortion in the summary of benefits. It's not transparent whatsoever. I don't know if this is true in any other state. All I know is in my state, you can't do it. Do you believe it should be fully transparent to the person visiting the website?
I think it should be transparent, what all the
Very
benefits
much.
are.
Now, let's go, and just so you know, it's not transparent. So when you look at these websites and provide oversight, please make sure, and this is not just from us, I mean, Planned Parenthood of Northwest has made the same complaint. It's very obscure, you
I
can't tell.
understand. I think people should know what the benefits are.
We're going to agree, you see? We're going to agree on something. Now, let's go ahead a little further, though, and talk about the billing because the Maryland Insurance Commissioner she has said that in fact, the insurance companies don't have to invoice separately for abortion coverage and non-abortion coverage in plans that cover abortion. I mean, literally, she has said that. I assume that the plain reading of the law that says there has to be a separate charge means that you actually have to be able to determine a separate amount somewhere. Is that correct? Is that your interpretation of the...
Again, I can't speak to what the Maryland Insurance Commissioner said or didn't say, but I can assure you we will follow the law in the federal marketplace.
But you actually have to oversee all the exchanges, don't you? Not just the federal marketplace, don't you?
Well, we have supervisory authority.
Correct, you do.
No, sir, the state marketplaces run their marketplace. They qualify the plans, but they have to follow the law also.
Correct. So if in fact, the Maryland Commission, if in fact that is her determination, that there doesn't have to be even a separate invoicing of it, that would in fact be a violation of the law. I'd be happy to take a look at what she said and follow up with our team. And I hope you do, because, again, the reading of the law is pretty plain to me. Now, let me ask you a question, because this was brought to my attention by an insurance agent in my state. April 1st comes. April 10th. Somebody sees a rerun of the, Between Two Ferns deal. And a young, healthy patient says, you know what? President convinced me. I want to go out and I want to be insured. Healthy young person. Exactly the kind of person we want on our exchanges. They can't, can they? In most states.
As any in open enrollment, they need to wait until November 15th when it opens again.
So we designed a system where that healthy 25-year-old who wants to buy insurance on April 15th can't buy insurance. Now that is different. The system before, and look, I agree with the ranking member, there's plenty wrong with the system before. But I will tell you that on April 15th, a healthy young person could have gone out and bought a policy. So when that healthy young person, God forbid, has an accident in August, a devastating accident, they can't, but let me follow up. The individual market, and the ranking member suggests go to the individual market. Those policies can't be purchased unless you have a qualifying event. Those policies can't be purchased, can they? No.
Yeah, they can, absolutely.
They can be purchased where?
They can be purchased outside the marketplace, in the individual market. They cannot qualify for a tax credit until the next open enrollment season. But they can purchase an insurance policy at any time. They just can't use the open enrollment through the marketplace and qualify for a tax credit.
And, Madam Secretary, in Maryland, it's not available. In Connecticut, only one plan.
What's not available, sir?
That purchase of that policy on the individual.
I don't think that's correct. I think in every state, there are individual policies sold inside and outside the marketplace. Dr. Harris, if I might take a moment, I want to correct a statement I made earlier to, even though Congressman Joyce is not here, I've been told I misspoke, and I did that unintentionally. The shop data enrollment is not in the current enrollment report, but I will give him the information that we have and send that up today. But I just wanted to make that clear.
Thank you very much, Ms. Lowy.
Thank you, Mr. Chairman. Before I ask the question, our ranking member would like 30 seconds.
I thank the gentlelady. I think Mr. Fleischman has said that we share the concern that the healthcare system was failing people and that we needed to reform it. Well, I would just like to mention to you that we had 6 years of a Bush administration where, if that was the case, nothing was done to address it. We waited 100 years to get an Affordable Care Act passed. The majority today, as it did when those of us who were here were going through this process, the majority has no program, no plan, except to repeal it. If you have a plan for dealing with affordable care for the people of this nation, I would please ask you to come forward with it and just lay out what it is that you would do.
Will my friend yield? I do have a plan. But I do have a plan.
No, Mr. Fleischman would not yield to me, so I
Okay.
asked Mrs. Lowy if she would yield me 30 seconds. Mrs. Lowy.
Unanimous consent that won't be charged against you, and I just want to make sure my friend, the ranking member, said, number one, unfortunately, I'm going back and forth between defense, so, and I got some issues across the hall, so that's why I'm not here. But when I come back, I will always be happy to yield my friend time for a good spirited discussion on any subject.
Thank you, Ms. Lowy. You're up. We stopped the clock for that.
Thank you so much. And before I ask my question, again, I mentioned John Porter and how we work together in a bipartisan way. And as with any large program, whether it's Social Security and Medicare, there have been revisions. So I do hope that we can be constructive, not only in these hearings, but in other discussions. And if there are specific changes that you would like made, we could hope we can have healthy discussions to amend it. You've seen that happen as we move along. So, I'd like to ask a question about autism. It's amazing. I go on an autism walk every year, and the numbers are just increasing tremendously. As prevalence rates have increased, and we know the rates have increased dramatically in the last 20 years, there will be increased demand for services for children and young adults. Could you share with us how the budget request helps families and individuals with autism?
Congresswoman, I would say several things. One is that if a family has a child or even an adult with autism, that individual will now qualify for health insurance where they may not have in the past if that family was in the individual market. That's a big step forward, just in terms of underlying care and being able to access it. There's some very important research underway at the National Institutes of Health. And as I mentioned before, the project that is involving drug companies and the NIH identifying some diseases where they will actually share preliminary research, share target opportunities, try to identify some formulas that work to accelerate cures or rescissions. Autism is one of those areas, and I think autism is one of the areas in the brain mapping structure that will be focused on by the NIH, and I think that bears very promising resources. We also have an autism working group coming up with a series of strategies and suggestions, everything from hospice care and home-based relief care to strategies about community events and enhanced research that is part of the ongoing autism effort. So I'd say there's basic underlying care, there's additional research, there's additional funding, but again, I think the need is huge in this area, and as more identification takes place of who all is in the autism spectrum, those numbers grow.
And so, in addition to the research, I do hope we can get together to, whether it's HRSA, the Institute of Community Living, there's a lot that we have to do. Is my time up? No? Okay.
15 seconds.
Okay. Let me just say in the 15 seconds, I've been working on food allergies, celiac disease for a long time, and I probably don't have time, but I hope you can share with me at another time CDC's efforts to disseminate the voluntary guidelines to schools and the department efforts, because this is a really important issue.
Be happy to do that.
Child has an anaphylactic reaction. Too often, too many people don't know what to do. Thank you, Mr. Chairman.
Thank you. Ms. Roby?
Thank you. Just a quick follow-up on my first line of questioning. There was an article that came out today. The insurance industry takes issue with the administration's claim that you did not have the information that I asked and that you testified about yesterday. The insurance industry says that they have a lot more information than they're letting on, and they have real hard data about the percent that have paid, and speaking of the administration, if they've not processed those yet and compiled the data, that's a choice they are making, but they have the data. So the insurance industry obviously takes a different position than that of this administration. But I have short time, and I've got another important line of questioning that I want to ask. According to Paul Bedard, writing in the Washington Examiner last week, and I quote, Planned Parenthood is going to bat for the White House, hosting more than 500 events in 18 cities to get Americans into the health insurance system. In 8 states, officials from the women's health and abortion provider will go to grocery stores and even indoor soccer field to enroll people. It also plans to dispatch 500 canvassers and knock on 20,000 doors. Earlier this year, the New York Times reported that Planned Parenthood is one of the most aggressive groups going door to door to enroll individuals into Obamacare. And last year, we learned that Planned Parenthood affiliates received at least $655,000 in Navigator funds to help with Obamacare enrollment. And I'm sure you know Planned Parenthood is the largest abortion provider in the nation, carrying out more than a quarter of all abortions in this country. So I would like for you to tell us, has the 500 events, 18-city Planned Parenthood enrollment initiative that I mentioned received federal funds, and what is the total amount of Obamacare-related funding that has been directed to Planned Parenthood or its affiliates, either directly or as a grantee or subcontractor?
Congresswoman, I can get you the information on the Navigator grants. I don't have that state by state. Those were competitive grants of known community organizations, and I'm happy to provide that. The activities that you talk about are ones that I assume the organization is conducting. They have no funding from the federal government. I do think that Planned Parenthood is a provider of preventive care across this country. Over 6 million people get cancer screenings and
can I stop you for a
well-woman
second?
checkups and contraception.
Can you please, for this committee, because this is a very important issue, can you please provide for us at some date certain, by end of next week, and guarantee us that you will give us an itemized list of each grant or contract and that
I can tell you the Navigator grants,
that has been made available to Planned Parenthood or a Planned Parenthood affiliate under Obamacare.
I can give you the Navigator grants, which, as I say, were competitive grants in communities across this country.
If you could get that to us, that would be helpful.
Yes, ma'am.
According to April 12, 2010 edition of the New York Times, President Obama agreed to volunteer to enroll in a health insurance exchange. For the record, will you tell us what political appointees at HHS have enrolled in the health insurance exchanges?
Well, I think you'll be pleased to know that I don't access people's personal information, and so I cannot give you that information, nor will I ask anybody about their information. Their employee coverage is paid for as part of the federal plan. The marketplaces are for people who don't have coverage in the employer market, and if you have affordable employee coverage, I assume they'll stay where they are.
The point is this. If it's good enough for the American people, it should be good enough for political appointees.
It isn't about political appointees, it's people who don't have affordable employer coverage. Federal employees, state employees have affordable employer coverage, and they would not access the marketplace.
We today have spent time, and we have differing opinions, obviously, but we have spent time today pointing out deficiencies that we see in this law. And again, I just think it's important for the folks back home in Alabama and people all over this country to know that that the federal government is not exempting themselves, that they are mandating that the American people have.
No one in Alabama who works for one of the new auto factories who has a employer-based plan will be accessing this marketplace. No one who works for city or county government will access this plan. This is for people who didn't have employer coverage, affordable employer coverage, and they now have an option.
Thank you. Ms. Lee?
Thank you very much, Mr. Chair. First, let me just say to you, Mr. Chair, and others who made a comment about the Affordable Care Act not being bipartisan or receiving one Republican vote. I, during that period, chaired the Congressional Black Caucus and led many of our efforts in, Mr. Chair, I want to mention this, led many of the efforts on the negotiations on the Affordable Care Act. Much to my disappointment, our leadership and the president accepted many Republican suggestions in the Affordable Care Act, one by one by one. Not one single vote on your side. So I can't sit here and let you say that we didn't get bipartisan support, when in fact the president and our leadership reached out, incorporated many of your suggestions, and you all still didn't vote for it. And I was there, I saw this go down, and I think many of us understood what was taking place. And I was very disappointed, but in the spirit of compromise, we went along with it. Let me say to you, Madam Secretary, I want to commend you and the administration based on what we're seeing as it relates to HIV and AIDS and other sexually transmitted infections as it relates to young people in terms of preventing teen pregnancy. I want to just see, how does the budget reflect this ongoing commitment, because I think you all are doing a really good job in helping developing comprehensive sex education for young people. And then secondly, I serve as co-chair of the Congressional Asian Pacific American Caucus, and of course we've been dealing with this issue as it relates to inadequate translation services provided to limited English proficient populations, both in the translated applications as it relates to the Affordable Care Act, the call centers, given that there's so many different languages. And so how does this budget, help address the issue of linguistically appropriate services in healthcare and the exchanges, and to get the information out and help those who need to understand how this works?
Well, let me take the last part first. We share your concern that this is a very diverse and rich country based on its diversity, and having language-appropriate information is essential. So the call center can answer questions in up to 150 languages. We have printed paper applications in 5 languages. That is not enough, and we are looking at what resources we might need to expand the paper application process so that we could have more printed applications available. The website, as you know, is available in Spanish and English. Again, one of the goals is to look at how culturally diverse the website could be. We have, it would be, I can guarantee you, virtually impossible to have the website in every language that's spoken in this country. So having translators available, having a variety of help available is one of the things. We're also looking at how we diversify our navigator force on the ground. So even if you can't go to the website in your native language, you may be able to have someone on the ground. All of those are underway, and with the resources available, we're trying to take that very seriously, gathering information from what we know now where the highest problem areas and where the markets are. I would say in the HIV/AIDS area, you know that having a domestic agenda is a first time for this administration. It never has occurred before. We are taking that very seriously, focusing resources on the high populations at risk and the high communities at risk, and certainly testing, treatment, and access to ongoing treatment are the 3 areas that we're refocusing on, trying to get rid of some of the stigma around testing, but also making sure that people are routinely screened and come forward, and then connecting them to treatment and keeping them connected to treatment, because that is a very effective life-saving strategy.
And finally, I have a few more seconds, I just want to say that this subcommittee really is the subcommittee that can address issues as it relates to poverty and income inequality. We passed several amendments to all of our bills talking about and laying out our efforts to reduce the existence of poverty. So I hope in this budget we can see some anti-poverty ladders of opportunity provisions and a way to really address income inequality through your agency.
Thank you, Mr. Stewart.
Yes, Mr. Chairman, and I understand you'd like me to yield you 30 seconds.
Thank you very much for yielding 30 seconds. Madam Secretary, in response to the last answer that you can buy insurance on the individual marketplace after March 31st, you ought to tell USA Today, Kaiser Health News, and AARP, all publications that say You can't do it in the individual market or the exchange after March 31st. Yield the balance of the time to Mr. Stewart.
Thank you, Mr. Chairman. Madam Secretary, I admire your courage. I really do. I think you have this incredibly difficult task of defending this law before the American people. And I'm so glad that I don't have to do that. I was a small business owner. I know how difficult it used to be and how hard we worked to provide adequate insurance for my employees. But I'm telling you, this is worse. In many ways, it's much worse, and the American people know it. The health insurance program that we had before in this country wasn't perfect. I don't think anyone's ever claimed that it was. But the vast majority of Americans were satisfied, which is why we told them, or the administration told them, if you want to keep your doctor, you can keep it. If you want to keep your health insurance, you can keep it. And we now, of course, know that that's not true. Much of that turned out not to be true as well, of other specifics of this law. I'd like to talk just quickly about the innovation centers, which, and I'm quoting, they are created to provide innovative payment and service delivery models to reduce payment expenditures. Essentially, they're there to review and to fund grants. In 2011, there were only 68 FTEs that were involved with the innovation centers. This year, there's going to be 450, which seems like an awful lot of people to review and to, streamline this process of granting these government grants. Can you assure the committee that there's none of these employees in the innovation centers are involved in the marketplaces?
Congressman, there is no involvement of the Innovation Center in the marketplace. There is one Innovation Center. It's a center in the department, in the Agency of Centers for Medicare and Medicaid Services. It is funded through the Affordable Care Act. And I would say for the first time, we have a research and development arm aimed specifically, and it isn't about the marketplace at all, it's aimed specifically at how quality can be improved and costs can be lowered for Medicare and or Medicaid programs, the big public programs run by CMS. That's what the aim is. I think the work that they're doing will benefit everyone, even if you're not in Medicare and Medicaid, because things like lowering hospital-acquired infections, looking at preventable readmissions, looking at elective deliveries that could cause long-term harm to infants. Those kinds of efforts are very much underway, and but it has nothing to do with the marketplaces.
Okay, and you as well, you can assure us then that they are not involved with the implementation activities of Obamacare.
That's correct.
Okay, thank you. In recognition of the shortness of time then, Mr. Chairman, I will yield back my last 30 seconds.
Mr. Womack. Okay.
Thank you, Madam Secretary, for your testimony here this morning. I apologize for being late. Sorry I missed a lot of it. But at a House E&C hearing back in November, Henry Chow, the CMS Deputy CIO who oversaw technical development of the exchanges, said there were some back office functions that were not complete yet. And I want to go straight to an issue that's relative to my district specifically. I've got the largest home of Marshallese population in the United States. Many of these individuals have Medicaid qualifying incomes, but are, as a COFA migrant, they are not Medicaid eligible. However, they are eligible for the premium subsidy under the Affordable Care Act. But as I understand it, their applications are being kicked back and forth between the state, which cannot provide Medicaid coverage, and the exchange, which cannot process the applications, ultimately bouncing the applications out of the system on the back end. And I know the Arkansas Insurance Commissioner has sent word to D.C. that they have this problem, so I'm asking, are the back office operations and IT support functions fully operational and secure?
Sir, we are in the process of testing state at a time all of the Medicaid inbound and outbound. They are built, and each state has a slightly different system. What we're finding in some states, and I can't tell you off the top of my head if Arkansas is one of them, that the state is not able to receive the automated accounts, so we're doing a more manual workaround. But we have a very high priority to make sure that people who are eligible get enrolled in a timely fashion, and we will do that.
Can you give us a timeline?
Of enrollment?
when these functions will be operational?
Well, as
When you
I-
can get back to Jay Bradford and say,
They are operational now at the federal level, both outbound, so if someone comes to the federal website and appears to meet the state qualifications for Medicaid, they are automatically sent to the state. Some of the states can receive that automated information now. Some states do not have the capacity to do that, so they are sent more a paper file application. When someone comes to the state and appears to be qualified for the marketplace, they are referred the other way. So the automated functions now are built. We are testing a state at a time to make sure that they can receive back and forth.
would it be an unreasonable request to have somebody from your office contact the Arkansas Insurance
at all.
Commissioner? And
I'd be happy to.
And close that loop?
Sure,
so that okay.
absolutely.
And then finally, and I know I'm closing and you've got a hard time to be out of here, the President's budget released last week proposes nearly $35 billion in additional Medicare Advantage rate cuts over 10 years. It's a huge thing for my district, as it is for a lot of people. Can you guarantee my constituents that they won't lose their Medicaid Advantage or Medicare Advantage plans?
Absolutely. Medicare Advantage, I think, Congressman, is a very positive story with the Affordable Care Act. The allegation, and it's already been said that many of the members were not here in 2010. The allegation was very much that if you pass the Affordable Care Act, you will destroy Medicare Advantage. No one will have a choice. It will be gone. Just the opposite has happened. Enrollment is up 30%. Premiums are down almost 10%. More enrollees are in higher quality plans than were in 2010. We have seen a very positive growth in the plan. We anticipate that that will continue. What's happening, though, is insurance companies are no longer being overpaid based on the care that they're delivering. The fees are closer right now to a fee-for-service in Medicare, and so I think that we see that progress continuing.
I thank the Secretary. Thank you, Mr. Chairman.
Thank you, Mr. Womack. Madam Secretary, we appreciate your being here today. I do want to close with a few quick questions, and we can do those for the records, and members will have 2 weeks to submit further questions. I am concerned about the advertising budget. I think it's about $770 million, and yet it will be past the enrollment period, so I'm not sure why it needs to be so high.
Sir, I don't really, I wish we had $770 million of any kind, but I don't know what we're...
Consumer information and outreach, so
That's
maybe
the
redundant.
office, that is not advertising. The
Okay.
Consumer Information and Outreach Office is the office that actually manages the entire marketplace program, both at the state and federal level. Those are employees and the marketplace functions, but that is not an advertising budget.
Okay. I'm still concerned as to why we need that, but we'll follow up
I'd
with
be
some
happy to
questions.
give you
Yeah.
information about what they do. That's the third big center. in
Also, Ms. McCollum and I have been critical of some of the military recruitment ads as being ineffective, and I'm always suspicious when I see federal government ads anyhow. One that caught my eye, and frankly, as a male, it was very offensive, as a father of 2 sons, the Bro Insurance ad for health care. Not sure if that was a federal ad or one of the state exchange
It was
ads.
not a federal ad.
But it had young men doing handstands on a keg of beer. And so what I'm just interested in, I'll follow up with you in terms of how effective some of these ads are and what kind of metrics you use. Because we found with some of the military ads, they did not have metrics that showed the effectiveness of it.
I'd be happy to share with you what the CMS folks found in focus groups and others on, in terms of the advertising, but the Bro ad is not ours.
Okay, because I know there was another one that was not yours also that they had in Colorado. The other thing, getting back to Ms. Roby's question about political appointees and Obamacare, the president did sign up very visibly on December 23rd about it, and I think that what the concern is Congress has had a lot of public input on signing up Congress, signing up our staff's subsidies for them, and so I think the question is, and I will submit it to you, is on political appointees in general and their staffs. Also wanted to ask you how navigators get rated in terms of their effectiveness. And then switching gears, and Rose, I don't know if you saw this, but Patrick Kennedy was on TV, and he's is a former colleague of ours, and he had very publicly some drug issues, drug addiction issues, and he is very concerned about marijuana. And one of the things he said that caught my attention is that the states are getting so many tax revenues and there's so much profit in it. And he said, yet their natural market is going to be teenagers. And they're going to make sure that it's very attractive to teenagers. And so as we go through this murky water of state laws changing contrary to federal laws, it's something that I think your agency needs to be very concerned about. And then kind of getting back to what Dr. Harris said is, is there a position of Health and Human Services that medical marijuana or marijuana in general is more harmful than tobacco?
Well, I would be happy to get you, we certainly have done a lot of research and a lot of information. I'd be happy to get that to you. I can tell you that there certainly are harms and some long-term brain harms that go along with smoking marijuana over a period of time that have been clearly documented. There's a lot of public health information. But I would also tell you that there is no comparison in terms of health risks for someone who is smoking tobacco and addicted to nicotine versus marijuana in terms of cancer and death and secondhand smoke. So there are dramatic health differences, but I'd be happy to present the information.
All I would just say with regard to that, Mr. Chairman, is, and I was did a press conference on these new e-cigarettes and these e-hookahs, that's an area that we ought to be trying to focus on, where young kids with the tobacco industry, the way they marketed to 12-year-olds for cigarettes, because that was their new market, they are now marketing again to 12-year-olds for e-cigarettes and e-hookahs, but the information is 480,000 people die every year from a tobacco-related illness. Now, we went to war in Afghanistan with the 3,000 and almost 4,000 people who died, and yet we continue when we can prevent these deaths from tobacco. Thank you.
The marijuana thing is, just when I heard Patrick talk about it, really caught my attention. But thank you very much for your time, and thank you,
Mr.
staff.
Chairman.